Thank you for joining us today. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. And today we have with us Zachary Benedict and Andrew Mitchell from MKM Architecture and Design. And they've got a fascinating program that they're going to share with us today about bridging the gap and the impact of telehealth on community well-being. And uh, this is a really important topic as we have so many more elderly aging in place at home. Just a few housekeeping items before that we get started today. We are recording today's session. We will post it on our YouTube page. And Zach and Andrew have agreed to share their slides, so those will be posted on the archived webinars on our website. We have all of our attendees today in listen-only mode. If you have a question, please use the Q&A function at the bottom of your Zoom window. If you have technical issues, please use the chat function at the bottom of your Zoom window. We will hold all questions until the end unless there's something really important we need to jump in. And then we'll come back at the end and hopefully have time for some questions. All right, you guys want to take it away?
Sure, thank you.
Mm-hmm.
Thanks for everyone for joining us. We think this is a really interesting topic. We're going to just jump right in and hopefully leave some room at the end for questions. One of the ways I'll preface this is, here at MKM, we're an architecture firm, so to for a hammer, every problem kind of look like a nail. But when we look at things like design, what we're really trying to do is understand how we can qualify what constitutes good design by its ability to balance independence and health. And we would argue that that is something that needs to be considered when you're designing a new facility or a new healthcare system or a new service, and trying to understand how that balance can impact how we perceive and define quality of life. A better way maybe to say it is, we like this quote by Wendell Berry, who says, "I believe that the community, in its fullest sense, a place in all its creatures, is the smallest unit of health, and that to speak of the health of an isolated individual is a contradiction in terms." The reason I think that's important is because it starts to define health as something that is very contextual. And as architects and people that are dealing with more innovative healthcare systems and delivery models, we're in the context business. It's our job as care providers to understand how the services and programming and goods that we're trying to provide can in some way elevate the quality of life and well-being of the people that it's using it. What we want to talk about today is blurring that line of usage and trying to understand how some of these strategies can not only help those that are seeking healthcare, but also elevating the amount of well-being that a place in its essence can provide or impose on the general public. And trying to understand what that might look like and how telehealth can understand its role within the evolution of that, especially after something as transformational as the COVID pandemic. One of the things we'll often hear is this idea that rural well-being is a pretty consistent thing that has similar issues that they need to address. And I don't know if that's necessarily true. Some of the most highest scoring on a well-being index states in the country are as rural as the ones that are in the bottom 10. In some ways, it's not a rural issue as much as a Midwestern problem, one that I think has unique challenges that we need to take a special look at trying to understand how we can address in a more meaningful and sustainable way. So when we look at things like the determinants of health, we're really trying to set a baseline for what we're talking about in hopes that we can make some meaningful changes and improvements. I can get a lot closer to understanding the likelihood of your expected lifespan. I can tell when you're going to die probably more accurately by your zip code than your genetic code. And that's really as a result of how we've developed, managed, and operated our communities over the last 50 to 70 years. And the social determinants of health really start to tell us that story. Individual behavior and social economic factors play the majority of the role in defining what those determinants actually are. And access to quality clinical care has little impact on those results. So in trying to understand that, the question is, well, how can telehealth have a role in that as cities and towns across the Midwest begin to redefine how they're approaching some of these problems? One of the things that I think is important to do is to reconsider how we're addressing or defining well-being at its core. Gallup does a research project every year where they issue the well-being index of individual states. And you can kind of see that blip in the middle that we'll call the Midwest, but traditionally scores in the bottom quartile of states in terms of well-being. And when we look at those kind of scores, what we're really looking at is a culmination of a couple of different discussion points. In this case, 5 key components. One is purpose, liking what you do each day and having enough energy to achieve your goals. Second is that social well-being, having supportive relationships and love in your life. Financial well-being, managing your economic life to reduce stress and increase security. 4 is that community well-being, liking where you live, feeling safe and having pride in that place in which you call home. And then finally, the 5th one is that physical well-being, having good health and enough energy to get things done. How those 5 things intersect is really how we understand what we're talking about when we're looking at things like well-being. What challenges us here is that for those 5 indicators across the lifespan, they continually change. So when we look at these aging projections that are now becoming so commonplace throughout the Midwest, we really have to ask ourselves, how is this going to impact our well-being as a community in the next 20 to 30 years? You know, for example, in the state of Indiana, between 2005 and 2040, our population is projected to grow by about 15%. Our 65 and older population is going to grow by about 90%. And in rural communities, that number is probably closer to 120 to 130%. So when we look at the health and well-being of a community as a system, how is that going to impact those 5 categories with such a different and evolving demographic? One of the things I think we're going to have to do is try to understand how health, especially telehealth, can look more upstream. So, you know, conventional healthcare services have consistently lived in what we'll call a downstream environment where they're reacting to a specific need. If I get sick, I search out a physician and I receive care. But if we're really going to tackle this in a more sustainable and meaningful way, these discussions have to move further upstream from everything from social capital to telehealth to urban planning and municipal zoning ordinances, and understanding how those decisions that we're making as a community impact the quality of life of the residents who we claim that we're here to support. So this idea of upstreaming these initiatives and these strategies, I think, is really critical to this discussion. The other one that's important for this, and what we're going to spend some time talking about today, is the fact that there's a mounting evidence that a rich network of face-to-face relationships can create this biological force field against disease. Our ability to interact with the people within our everyday routine really does define and insulate us from specific clinical outcomes. One of the more telling things, I think, is when you look at the data that discusses how you can reduce the chances of dying prematurely the most. The top 2 aren't what you would likely think. You know, on that list is kind of the heavy hitters: clean air, hypertension, cardiac rehab, don't drink, don't smoke, make sure to exercise, lose some weight. You know, all those kind of common strategies. But the top 2 are close relationships and social integration. Social integration is kind of your network of people that you know, a friend of a friend, and it really is the gateway to opportunity and success. Close relationships are more of an emotional tie. These are your really close bonded people, the ones that would actually come pick you up at the airport if you asked. And those 2 are very different types of relationships in our life, but they play a specific role in how we understand them. The reason that's important is because of this epidemic of loneliness that we've seen over the last couple of years. We as a country are extremely lonely, and that has had clinical impacts on how we understand not only the healthcare system, but how we perceive our quality of life in the communities in which we live. For instance, half of us think that we have a meaningful in-person social interaction on a regular basis. And this was before COVID. Once COVID hit, more of us got to feel really what that was like, and understanding the stress and the demand of isolation and what it can do to our perceptions and just how well we felt on a day-to-day basis. That feeling of loneliness is an interesting thing to look at. It's really an evolved cognitive alarm. It's your brain's way of saying, you know, be careful, you're being separated from the tribe. And we've had this kind of trigger in our DNA for a long, long time. And that impact, if it happens over prolonged periods of time, can have can cause some real problems with our social determinants of health. That being said, the inverse is also true. Women that have large networks of friends are 4 times more likely to survive breast cancer than those with sparser connections. This idea of social connectivity really does play a large role in not only how we perceive the world around us, but what our quality of life eventually becomes. And there's a lot of ways we can do that. More specifically, over the last year, there's a lot more ways that we've learned we can do this effectively. Everything from making sure we stay in connection with our family and friends over social media, to trying to interact with our neighbors in a more meaningful way because we weren't pursuing things like restaurants and events and social functions, or making sure that we stay connected with family and friends through chat and video. At the end of the day, what we're really looking at is trying to understand how this idea of well-being can culminate in a sense of happiness, a sense of joy and pride with the places in which we live, because that connection, that attachment to place has a lot of economic benefits, but also plays an enormous role in our health and well-being.
And I think with that, looking at the social interaction, that leads into how the system of care is evolving, and how definitely COVID has caused that to accelerate faster than we anticipated. Looking at how healthcare is provided pre-COVID to how it's being provided now, less so a more bricks and mortar approach to more of a strategy looking at how we can provide a variety of touch points with patients and providers, and also how that becomes more of a strategy to engage those who are less and less connected due to health system consolidation or other changing care methods. And we know that shrinking care networks has had a disproportionate effect on rural populations, and this statistics growing. Since 2010, 82 rural hospitals have closed nationwide, and that's a matter of either becoming financially insolvent or through consolidation. And we know that within the next 10 years, there's as many as 700 that are at risk of closing or reducing their delivery of care due to not having enough patients or a good provider mix of insurance providers to keep a hospital solvent. And thus, that creates a disproportionate access to care for rural communities. And it just causes issues such as chronic disease and other phenomena such as the opioid epidemic to become more prevalent within these communities that are falling at the hands of community members and not the healthcare professionals that are needed. And how cities are approaching this is one of the ways that we're examining this trend moving forward. And some of this is to do with how we engage with a variety of providers, from some recent trends within healthcare facility design and operation, looking at different types of structures, whether it's through a multi-channel experience for users. Our future healthcare systems will likely adopt a more omni-channel approach to the built environment that accepts a larger community as an extension to the healthcare system itself, but also looking at different modalities and interactions for patients, to where you're not seeing the providers all in a fixed location, but you're conferencing them in as part of a consult network without the expense of hosting them in person. And then again, with COVID and how it's impact our health systems, telehealth and rural healthcare facility closures were part of a larger discussion to better understand how not only buildings but systems can be more resistant to future pandemics or the next crisis. For example, we're looking at infection control differently. and it's being considered from a facility planning standpoint to not only define the capacity for surge due to a pandemic, and also patient safety. Social distancing has become a buzzword within planning, so that we can effectively look at how these spaces could be adapted for future use. And this kind of upstream thinking will see traditional healthcare facility managers as valuable resources in rethinking the operation of not only their health systems, but also civic spaces within the community, and how those can be integrated within the larger care structure for the system. And thus, I think important telemedicine is becoming a more important part of that system, and the continued development of effective care models has really shortened the previous hurdles with telemedicine, so that the connection between physician care and tangible healthcare facilities has become a positive, so that soon virtual physician visits will outnumber physical encounters, as effectively reshaping the culture of healthcare facility design and management. Less single-use spaces and more multi-use spaces, so that we can become more flexible and look towards the future. And I think what's important with telemedicine is how it can facilitate a broad range of interactions with different devices and modalities. Again, looking at the interactions, not only from patient to provider, but from provider to provider, looking at how we can reinforce and bring in specialties that don't have the patient population to support an in-person visit, but also providing the access to their expertise virtually, whether that's through a smartphone or a tablet, looking at how we can integrate smart devices, creating an Internet of Things to provide better methods of care, especially for patients with chronic diseases, looking at how it can improve clinical outcomes with those connected systems. But also, again, getting towards interacting with the patient through video conference or over the phone using secure messaging, so that it becomes more of a care model that's at the convenience of the patient, and less a scheduled visit. So when an instance or an issue occurs, it's happening real time, they're interacting with the clinician as opposed to waiting for their next scheduled appointment. And then also looking at how we can integrate the home as another care location, in addition to a clinic or office or the hospital. And I think looking at how systems have approached this is an example from Kaiser Permanente, which you'll see a number of examples from them in this presentation. I think they are really at the forefront of integrating telemedicine within their overall care model, and looking at the number of ambulatory visits in person, over the telephone, and then through video conferencing, and how that's occurred throughout 2020. I think, as you can see, the spike of telephone interactions in April of 2020, and how towards the end of the year it became what I would consider probably more typical. As we see an aging population increase, that spike in April may become more prevalent and more of the norm, as opposed to an anomaly over the course of care throughout the year. And what barriers to that growth exist that need to be overcome, I think is important to consider moving forward. With that, and again, in rural areas, looking at how their infrastructure is catching up with urban areas, definitely are aware of limitations with broadband deployment, and how that is a barrier, especially with telemedicine. Looking at not only terrestrial access, but also other systems that are not newly implemented, whether it's satellite internet or improved mobile phone technology. But knowing that, there are those barriers that still exist, but also adoption amongst the elderly and people with disabilities, looking at how they can become easily implemented, and also what other barriers exist for people with in poverty or other low-tech literacy, just beyond the rural setting. Looking at this this analysis from the Kaiser Family Foundation, and I think this is important to consider how we're using technology. Across the top, you can see very few people I think this was a sample at 2 weeks in March of 2020. How many people have used a smartphone, a tablet, or a computer to talk to a physician or other healthcare provider? And you can see that very little adoption of that in a rural setting. But compared to how they've used that technology to interact with friends or family, you can see a broad adoption amongst 30 to even to 64. But once you get 65 and older, it's nearly a third that have done that. And so we still see barriers to entry and adoption, and how can we leverage other partners in the community to improve that access. And again, hitting in on that that same topic, this is graphic from a Journal of American Medicine study that looked at telemedicine implementation in 2020, and previously, fewer than 2% of primary care visits were conducted via telemedicine, and due to COVID, we saw that spike to over 35%. And I've seen studies that have shown it higher. But as you can see, as Zach pointed to previously, it's not a rural issue of telemedicine adoption. As you can see on the right side of the image, there are several rural states who have broad adoption, and some of it out of necessity. But if you look at the Midwest and even the South as in whole, very little adoption, and what we feel is that's due to more of a Midwest point of view towards implementing technology versus it being a rural issue. But I think there's some hope, definitely through technology investment, looking at how some programs within the CARES Act are allocating funds to increase broadband adoption and integration within rural communities, whether it's through distance learning or telemedicine program, looking how we can reconnect communities. We work in several communities where the public institutions are tapping into fiber that's run through the rail lines, that's only accessible through public entities. And so with those systems being in place, how can we broaden that to the greater public as a whole? But looking at how we can design and invest in these systems to enable communication and remote monitoring in rural communities, I think is important. But we'll also recognize that even though these funding mechanisms exist, they're very limited in scope, and we need to look broader for greater implementation. Moving forward, looking at some of the barriers from a broader engagement with telehealth, and this study surveyed 2,000 adults again at the end of March in 2020, and you see almost over a third really didn't want to do telehealth because they preferred to meet with someone in person. They also questioned the quality of care, and whether they could effectively diagnose their the cause of their issues through virtual means, but also, what that peer-to-peer interaction would be, and how comfortable they would be speaking with someone that may or may not be in their community or from their community, and looking at how that affected their perception of telehealth. This is interesting to us, but this is a University of Michigan study that asks a similar question, and 75% of the respondents had concerns that they weren't able to conduct an effective exam because they weren't in person, and they thought the quality of care wasn't as good. It was interesting that the other methods of that providers use for in-person physical exams was also brought up, that sense of smell was a key diagnostic tool, which was interesting to us, that visually there are a lot of things that present to clinicians from interaction with a patient, but there's also other senses that come into play that aren't necessarily as effective through telehealth. But we know that that's not necessarily the case, that telemedicine can lead to similar outcomes as face-to-face delivery of care in the management of patients, specifically patients with chronic diseases and disease management, using connected devices and an Internet of Things to constantly monitor the disease management. Also, more preventative actions can be made because of that constant stream of information, as opposed to being more reactive from relying on the next in-person visit, which may be 3 or 6 months away. And from that, what it does is it creates a better clinical outcome for those patients by leveraging telemedicine as not necessarily a replacement for in-person care, but another tool to be used by the clinical teams. And I think nothing is as more important as how it benefits behavioral health, especially in rural settings. We know that behavioral health services are often limited, if there are any provided at all, with rural health systems, and how telehealth can be leveraged to bring in those professionals to provide consults real time, so that the patients who need that type of care are served without needing to be transferred to the next tertiary facility. And so what I think COVID has really not only exacerbated due to isolation and other means, but it has advanced the use of telehealth to serve those patients. And I think broader technology implementation and infrastructure expansion will only help to benefit that in the future. And so how do we take these technologies and these measures and overcome the gaps in the healthcare system, but not simply ask where are the gaps, but also defining the standards and ideals of care, and continually iterate toward these ideals. As we mentioned before, telemedicine or telemedical consultations do not approach the same level of fidelity that an in-person physical exam yields, but it does provide a level of care and a means and methods for clinical teams to interact with patients without that are not being served by their primary care teams due to either consolidation or closing of their local hospital or health system. And so what we're seeing more and more is the development of what we're calling health campus, where it's a collection of care teams and clinical models that are aware of the limitations of telemedicine, but are also leveraging the central location within these rural communities to provide an outpost for teams to when they're not seeing patients in person, they're interacting with them through telemedicine or through other connected means. And it's becoming a method of care that's part of the total care plan for that individual, and not a replacement for in-person care. And so redefining telehealth and how the changing landscape of COVID, due to COVID, again, we go back to an example from Kaiser Permanente and looking at how Americans work and live and how they seek healthcare and how these changing consumer models and demands on clinicians are driving transformation within the healthcare market. And we're seeing consumers seeking more on-demand, personalized access to healthcare whenever they need it and wherever they are. I know my own health system, I have an app that I've downloaded to my phone, and if I have any questions, it could be 3 a.m, it could be 9 o'clock in the morning, I can submit that through that app, and it'll have a response from a care team within 30 minutes. And so what that does in leveraging technology, it creates a shift in care delivery, so that not only are we eliminating traditional boundaries in healthcare, but we're enabling more low-cost virtual first care delivery, which I think creates a better interaction with patients and their care teams, so that they're more proactive as opposed to reactive to clinical issues. And I think with that, it creates a new variety of offerings to where care is provided, whether it's remotely through a tablet or a connected PC or phone. Again, extending more services into the home, where the home is more and more becoming a site of care, using technology to monitor and prevent chronic conditions. But ultimately what that does is that improves access and facilitates better health outcomes for patients, and ultimately improves patient satisfaction through greater engagement and a consistent service delivery for the patient.
You know, over the last year, we've seen a lot of changes in how care is provided. And in some way, with great necessity comes great innovation. We've seen things that we thought 5 years ago, you know, we'd be 20 years away, happen virtually overnight. And what that has done is I think really heightened the interest and the attention that telehealth is getting, especially in its ability to impact determinants of health within a rural context, and trying to understand what limitations those communities have, knowing their exponentially growing needs and what services like this can provide. What we've found, though, is in the majority of the research, and rightfully so, has been dedicated to understanding how to most effectively provide clinical care, which isn't necessarily the same as saying that we're using these tools and these innovations to ensure an increase in well-being. And those are two very different things. So taking, you know, everything that Andy's just kind of summarized in the current trajectory of kind of this industry and some of these strategies, especially within some of the more larger progressive healthcare systems, circling back and asking, well, how can these also at the same time create a higher existence of social capital within our community? So if we go back to the initial research that we presented at the beginning, it talked about reducing your chances of premature death, and a look at things like close relationships and social integration. The question is, how can we do these, especially with a growing older adult population and a struggling rural community condition? And the answer is they might be the very same strategies that we're looking at in trying to increase our ability to provide telemedicine. these digital platforms, these social connectivity through virtual channels becomes another way, another tool for communities to understand how they can elevate the quality of life of people of all ages and abilities. The question is, can we figure out a way to do them both at the same time? And I think that's a really exciting part of this discussion, because that social capital component now becomes critical to the delivery of care, and by and large legitimizes it as a large component to how we define successful delivery of care in this context. So one of the ways that we sometimes will look at it is, we understand that where we live changes how we live, and how we live changes why we live, and that connection between place and purpose is really strong. We also know that if we think or we have a perception that we can provide value in the communities in which we live, and we have some connectivity to the world around us, we tend to be happier. We tend to have a longer lifespan and a higher quality of life. The problem we're running into now is that this rampant growth of isolated individuals really limits the ability for these individuals to interact with one another. So for example, about 45 million people in America live by themselves, mostly older adults. Those that don't, there's still millions of people that only single source of connectivity is through their spouse, meaning we're about one funeral away from north of 60 million people living alone without any real contact on a weekly basis. So what happens if these telehealth discussions, these communications with caregivers, mental health providers, become that person, that connection to the outside world? They take on a larger burden than just delivery of care. They now become in some ways, the only way to develop some sense of social capital and connectivity to the greater world around us. And that's a big burden. That's a big responsibility that we're kind of putting on the shoulders of these telehealth pursuits. But I think it's a legitimate discussion to be having. Because when we talk about the development of social capital, it's important to understand there's kind of two types of relationships. And that's really what that means in that research when they say the difference between close relationships and social integration. Those social integration are what sometimes we'll refer to as these bridging relationships. They're, in a conventional sense, they're people that you kind of know in your peer group. You know, so-and-so's son, works at the local lumberyard. I don't know him, but I've known his mom for 20 years. So they're within my bridge relationship. I have, 6 degrees of separation between me and Kevin Bacon. And that's really what that means. Those are easier to cultivate with digital platforms. Tools like LinkedIn are built around this idea of trying to develop a robust bridged network of relationships. Very different from that is this idea of bonded relationships. These are these close emotional ties to a smaller group of people. These are families and friends, those at which you use words like love and admiration for. These are much more difficult to develop and sustain meaningful relationships with virtual platforms. What we found, though, is that there is a difference cognitively. Our brain understands a difference between visual cues and social media. So the example we'll use is research study after research study indicates that the more I use social media, the lonelier I feel. Millennials tend to be one of the loneliest cohorts when you look at it from a generational breakdown. People that have a high usage of video electronic communication don't necessarily have that correlation to loneliness, meaning if I live and die by Instagram, likely is I feel more lonely than those that don't. If I rely on FaceTime or video conferencing to connect with my bonded relationships, in some way that video, that facial recognition on the screen tricks my brain into thinking I'm having face-to-face contact. And I can develop and sustain meaningful relationships that are bonded to an individual. And that's important, not only in discussion of social capital, but in providing clinical care. When one of the biggest issues is a sense of trust, we're not going to get there unless we can figure out an efficient and effective way to have these face-to-face discussions. And the innovations we've seen in the telehealth industry, I think, are going to teach us how to do this beyond the realm of healthcare. One way to think about it is to look back at really just how we've historically developed our communities. So every community was really triangulated around kind of three core spaces. There was work, home, and these hubs, like the song on the show Cheers, where everybody knows your name. There was home was a realm of privacy, work was a realm of purpose, and these social hubs, bars, pubs, churches, were a realm of fellowship. The difference is these all now also have become realms to provide healthcare. They've become platforms of care. We've had to figure out how to provide healthcare in the home. We've had to figure out the importance of well-being in the workplace. And we're also going to have to figure out how these social hubs can help mitigate this sense of loneliness and develop a sense of belonging and incentivize a sense of well-being within the community. You're seeing a lot in these kind of retail clinics. They're taking what would be conventionally a third place like a grocery store or a market and tying within that and kind of a subsidiary to that brand, this idea of a quick check-in clinic, which are really popular because they're convenient, and we love convenience. What it's also done, though, is it's redefined that experience of seeing a physician. When you tell me that I have to wait and the process is going to take over an hour, I'm a lot less likely to do it. But if you can tell me I can do it in and out on my way to or from the grocery store, it becomes a lot more of an approachable thing. That hurdle of access is essentially eliminated. And the more creative we get about these partnerships, the more access I think we can give people to care, but also encourage them to understand that every component of their life in some way impacts their health and well-being, not just when they think they need it, but to move these discussions further upstream. A more progressive, I think, way to think about this is when people like the Mathers Foundation are trying to understand how they can essentially develop a coffee shop that's disguising a senior center. So the Mathers More Than a Cafe was a model that said, you know, we're going to operate this as though we were a senior center, but the word senior appears nowhere. And our staff is taught, incentivized, and encouraged to understand how to address and support an elderly population. But because the logo itself didn't pander to a specific population, about 49% of the people they serve are older adults, which actually attracts more older adults. So this idea that a cafe, something as silly as a coffee shop, now in some way is a platform to provide healthcare, is a really interesting and exciting way to think about how telehealth can impact the future of rural communities. The last one, and I think maybe the most exciting and biggest opportunity in this discussion is how we can better understand and leverage public libraries. Public libraries, by and large, are used by a lot of people to access health information. The majority of internet searches in public libraries are due to individual health. And they are growing their capacity to understand how they can support a population interested in these discussions, especially in underserved communities with populations of largely uninsured residents. And those libraries then become these really interesting civic platforms to have this discussion. They also become a really likely place for people to access telehealth when they don't have internet or broadband at home. So these now have become these really interesting, inclusive, diverse platforms for healthcare in a lot of ways. And what's exciting about that is there's still more public libraries in this country than McDonald's. So to think that this thing isn't sustainable is, I think, a little naive if unless you understand really the scope of these types of platforms, these types of civic stages in which we can redefine these discussions for rural communities. And we're starting to see that happen. The Philadelphia Community Health and Literacy Center, which was one of their branch libraries, took some underutilized square footage and essentially absorbed a clinic. And they see over 50 people a day. And what they saw is it increased the usage of preventative services like flu shots from their patrons because, and again, it goes back to this trust thing that Andy mentioned at the beginning. It's hard to convince people healthcare services are free. Healthcare systems have had a long history of having awkward discussions with consumers and patients about pricing and invoices. Everything in the library is free. So that trust immediately was increased. So when we offer things like flu shots, there was a much larger sense of trust that these were services for the general public at no charge. And it allowed people to come into the clinic without people understanding that that's why they were there. I'm either here for a book or to see my doctor, and you don't know which one's which. This idea, though, I think is really interesting because it's taking this discussion around telehealth and leveraging the innovations it has provided us in terms of better communicating with one another and connectivity between seemingly previously isolated populations, and providing us an opportunity to reconsider how we can use it to not only provide care effectively, but to increase social capital within these communities. I don't think it's there yet. I think the opportunities that were presented in front of us because of the pandemic has escalated these discussions, which I think has allowed some healthcare systems a really fascinating, I think, opportunity to understand how their services and their staff can play a different role in the lives and the well-being of the communities in which they serve.
And we're starting to see some of the benefits. People are actually trying to measure how some of these theories are in fact reality. And we point to a 2020 study by Bohan Farrell at the University of San Diego, where the researchers introduced weekly telehealth visits to reduce loneliness and depression among patients living in senior living facilities over a 3-month period. And what they found was approximately 80% of the patients had a decrease in depression, and over 60% of the patients showed a decrease in loneliness over that 3-month period as a result of the telehealth visits. So I think this is really important to emphasize the importance of how these types of care models can not only provide improved patient outcomes, but also help address some of the social capital issues that we've discussed today. And so what do we want to leave you with? And what are these best practices? And there are many that we discussed, but to simplify it, I think it's important for you to understand the determinants of health and how they impact one's quality of life and the role that telemedicine can play in the evolution of healthy rural communities. Leverage innovative partners to help not only redefine how health systems engage existing, but also potential users, as well as communicate the importance of healthy living to the overall community at large. Diversify user experience. Leveraging the fluid care models that provide an array of different points of service for a growing mix of consumers and patients, but also to create a consistent level of patient experience and outcome. And finally, think upstream where possible. Consider how strategic decisions of your health system can proactively impact not only the well-being of communities they serve, but through an omni-channel experience, but also acknowledge the importance of social capital in patient outcomes.
We'll stop there for questions.
Wow, I could go on listening to you guys for days. You bring up so many different opportunities and so many different thoughts. I think I could delve into any single slide and talk about it for hours. What was real, the stuff that you were talking about towards the end, though, about libraries and comparing that to the number of McDonald's, that really got me, because we've seen during this past year, during COVID especially, we've seen, so many kids displaced in their learning areas, as well as adults in their work, trying to work from home, and issues with broadband access, and issues with not having devices, smart devices, that have webcams on them, or, this, that, and the other. And I've heard so many stories of libraries opening up their Wi-Fi so that even if people come after hours and sit in their car in the parking lot, the kids can get their homework done, the parents can do work, those types of things. And to really think about how we would integrate in whatever fashion, if it's a telehealth kiosk, for lack of a better term, into a library. I think that's a fascinating idea that's got a lot of legs.
Well, and I think what will happen, just like in the Mathers example, where you're cross training a barista to be a social worker,
Mm-hmm.
whether or not we provide them this training, these staff at the library are functioning as care providers.
Mhm.
They are.
And deserve the support and training that we would expect a care provider to have.
Mm-hmm.
And that's not a discussion I think we're having enough of. This idea that every interaction, every face-to-face communication impacts health and well-being in some way is one way to look at it. The other way, which is a little bit more interesting to me, I think, is the idea that every single interaction from a telehealth exchange also then supports this idea of mitigating loneliness.
Mm-hmm.
There was a lot of social economic benefits to having a milkman that walked the neighborhood.
Mm-hmm.
We're not going to get there,
Yeah.
but we're also seeing with the older adult population, a lot of these communities, a huge growth in their exposure and frequency of exchange with telehealth providers.
Mm-hmm.
Do they have the training to understand not only to provide effective care, but the fact that it's worth 3 extra minutes to just see how people are doing,
Yeah.
be a friend, take
Mm-hmm.
notes, remember their hobbies, interests, you name it. The primary job of a good bartender is to remember what drink you like. That's really the first step in becoming a good bartender.
Mm-hmm.
I would put this at the top of the list of a good telehealth provider is
Mm-hmm.
to not only know the people you're serving, but know them at a level that they think now this is part of my bonded relationship.
Right.
And because they're not going to get that from the physician if this continues in this way, in this structure. They're going to get it through those virtual exchanges, those face-to-face exchanges,
Mm-hmm.
and we can't undersell how important those are for the well-being of those individuals.
Mm-hmm. That's so very true.
I think what's really interesting to us, especially from how telehealth is being integrated into care models, is the ability for that healthcare provider to actually see in the home
Mm-hmm.
of these patients. It's really easy to put up a facade when you're in a physician office and, how you doing? Oh, I'm fine. But having that glimpse into not only how they're living, but who they're living with, I think is an important diagnostic tool to better assess, their overall well-being. So I think going to where the patients are as opposed to expecting them to come to you is what's interesting moving forward. So where we're better addressing their needs as opposed to just checking a box.
Mm-hmm. I agree wholeheartedly. I mean, we've been working more and more with genetic counselors and geneticists who are now seeing patients at home, and then also an area that might even have poorer social determinants of health going on in their home is the WIC population. So we're working with a couple of states with the State Office of Rural Health or within their Department of Health, and creating trainings for the WIC providers. And then they don't talk about patients, they talk about clients, but it's the same thing. And we hear it from behavioral health providers too. It's kind of a double-edged sword, because sometimes you gather very good information about the environment around the person, but sometimes as a behavioral health professional or a WIC provider, you could gather some information that's kind of uncomfortable.
Mm-hmm.
A behavioral health provider is definitely is a mandated reporter if they think that there's
Right.
domestic abuse or violence going on in the home, so the silver lining, and I'm kind of a silver lining kind of person, is that we're able to provide more resources to those individuals because of what we learn about their surroundings. And you guys, community paramedicine is another area that is kind of similar to this discussion, where using ambulances or jeeps or whatever, EMTs and paramedics can go out and do those home checks. And my favorite story when this movement first started, probably 10 years ago, was a client that she was a frequent caller to 911. And so the doctor sent her out as she had asthma, and she would come into the hospital, be 24 hours observation, and go home just fine. But then another 24 or 48 hours later was calling in again, couldn't breathe. Well, community paramedics went out to the house, did a house call. You know, she's got 12 cats. Okay, so if you have asthma, you probably shouldn't have cats in your house. You know, these types of things that you're never going to find out in a clinical doctor's office in a hygienic environment.
Or even know to ask.
Right.
Yeah.
Absolutely. Absolutely. So, well, I don't see any other questions as we've been talking. So last call for questions here. And Carolyn, would you please put up the link to the survey in the chat? And we ask that our participants just take a couple of minutes to fill that out quick and easy. We are federally funded under the Upper Midwest Telehealth Resource Center, so our funders always like to hear information from us, and we always want to hear ideas for new webinars or other topics to explore in our webinar series. So thank you both again very much. I will make a definite tick mark in my agenda for the June IRHA annual conference. Here's a free plug for the June IRHA annual conference in French Lick, Indiana. Contact Carolyn or I and we get you more information. But look forward to seeing you in person there.
We'll be there. Thanks for having us.
Thank you.
You guys have a great day. Thanks.
You too.